Good afternoon, everyone. Welcome to the third session of the Commission and ANA's fifth Racism and Nursing series. Whether you have been involved in previous series or are new to this space, we are so excited to be back and hope this interactive learning space is a place for you to find guidance and support. Today's session is one of an 8-part series. You will be able to earn 1.5 contact hours for attending today's session. Please stay to the end to complete your evaluation and receive the CNE certificate. This series is brought to you by the American Nurses Association and the National Commission to Address Racism in Nursing, a multi-organizational collaborative of leading nursing organizations examining the issue of racism within nursing and motivating all nurses to confront systemic racism. The Commission and ANA remain committed to driving systemic change within the profession. The association's recent response to executive orders affecting diversity, equity, and inclusion underscores its dedication to advocating for inclusive policies and combating structural inequities in nursing. ANA continues to work with Congress and federal agencies to mitigate the impact of policies that threaten progress in health equity and workforce diversity. Please take time to scan the QR code to learn more about ANA's public statement, Protecting Healthcare for Americans. And we'll show that again later as well. Before we get started, let's review the ground rules for each of our sessions. Please remember that this is a brave space. Discussing racism and health equity is difficult and uncomfortable, especially for those directly impacted. Discussions such as these can serve as a trigger. So we ask that you maintain respect for everyone joining us today. Please stay on mute until it is your turn to speak. Listen intently and respond thoughtfully. Be present. Limit background distractions and multitasking as much as possible. Please take advantage of the virtual features available via Zoom. We do encourage you to turn your cameras on and use the chat box when we're in the breakout sessions. It's disabled at the moment for the session. We encourage you to raise your hand, and please, again, remember to mute your microphone when others are speaking. Please respect participant privacy. Do not disclose names or other sensitive information shared. If you do share a scenario involving a patient, please do not provide any PHI during today's call or any of our sessions. Feel free to send a direct message to ANA Practice if you have technical problems during today's call. Today's session, The Contemporary Landscape of Racism in Nursing, Where Do We Go From Here?, will be presented by Dr. Kenya Beard and a panel of experts, Drs. Kelly Bryant, Mary Jo Garcia-Dia, and Danica Sumter. I will now turn this presentation over to them.
Thank you so much, Kara. Good afternoon, everybody, and welcome to the third Equity in Action. Before we get started, I would like to first acknowledge that many in our country are suffering a significant degree of loss. Indeed, people are grieving, and just because we are not wearing Black does not mean that the pain is not palpable. Accompanying this loss is a variety of responses: anger, denial, depression. How do we move forward? Where do we go from here? I'm joined today by three illustrious colleagues who seek to infuse a degree of hope, a level of hope that I hope you will find inspiring and uplifting. We know that, and I hope you read the second report, Systemic Racism in a Contemporary Society, because we will be drawing a lot from that document. And the document opens up with the fact that despite historic rulings, landmark legislation, and constitutional amendments intended to dismantle racial inequality, systemic racism continues to shape the lived experiences of individuals across nursing and healthcare. So some may argue that racism was eradicated by the legal victories of the 20th century, but that way of thinking is dangerous because it underestimates the insidious and adaptive nature of racism. So in the commission's report, we quoted Wilkinson, who poignantly states, racism is not always overt, and I quote, it goes about its work sometimes in silence, cast in the guise of normalcy. So today, we're going to hear from our colleagues. And the first question, advance the slide, please. The first question that we have is going to go to Dr. Mary Joy Garcia, and it's what does contemporary racism look like? And how does it manifest differently compared to historical forms of racism? Mary Joy?
Thank you so much, Kenya. And thank you for ANA for having the opportunity to participate as part of the commissioner when the National Commission to Address Racism in Nursing was started way back in 2020. And based on the study that was done on October, that was fielded by ANA, 94% of respondents indicated agreement with the statement that there is some racism in the nursing profession. In fact, 76% of respondents attested to witnessing racism in the workplace. 63% reported personally experiencing racism, and especially with Black nurses, which is 92%, and of course, reporting experiencing racism themselves. So within the contemporary context, it manifests more in a subtle way, more in a systemic and institutional ways, in comparison to historical forms of racism, which was very overt and legally sanctioned. These forms of covert or unconscious racism are embedded within systems and structures. Using my hat as a nurse informaticist, I actually did a chat GPT to see how this information is being presented in contemporary context. And it did say implicit bias is manifested by healthcare providers or nurses that may unconsciously hold stereotypes about our patients based on race. So for example, believing that Black patients or even Asian patients have more higher pain tolerance could affect diagnosis, treatment decisions, and interactions. On the other hand, there's also microaggression, which is often unintentional, and comments or behaviors that are communicated in a direct derogatory way or dismissive messages, such as, for example, I hear this a lot from my colleagues when some people would go up to them and say, "Oh, you speak very well in English." Knowing that we grew up in another country, but we do have our medium of instruction in English. And of course, other types of workplace discrimination based on our color. We did a survey in the PNAA, the Philippine Nurses Association of America, as part of our continuing efforts to address racism in nursing and within our community. And some of the feedback that we have received includes members that may have fewer leadership opportunities. Some have also expressed being passed over for promotion, or there could be instances where there is a lack of mentorship because based on how they look like and of course where they're coming from. So in terms of structural racism, we heard this from other colleagues, especially in academia, in terms of policies centering and ignoring special health needs or cultural context of diverse populations. Putting my hat in the community, being part of Kalusugan Coalition. Kalusugan means health in the Filipino language. When we do this community-based participatory research, we hear common themes from our members in terms of having difficulty in accessing providers that might be able to understand them in their own language, or even trying to look for providers that look like them. So I think I'll end my discussion and have the opportunity to hear from my other colleagues.
Thank you, Mary Joy. Kelly?
I would say the biggest difference now is that racism is more from the past, more covert, insidious, and it's embedded within our systemic structures. So historically, it was kind of, racism was explicit. It was socially accepted. It was legally sanctioned through policies and legalization of things such as segregation, redlining, forced sterilization, voter suppression, and even acts of racial violence like lynching. So these practices were enforced by laws and normalized within our society. But today, it still exists, even overt forms of it, but it's more commonly subtle and it's embedded into our institutional practices and policies that come off as being race neutral, but they really are not, and they disproportionately affect marginalized communities.
I love that you emphasize that they come off as race neutral, but
They
they
try.
don't. So in
Yeah.
harmony with what Mary Joy said, it's systemic. It's in the policies, baked in. And like baking a cake, how do you take out one ingredient once it's already cooked? Danica?
Yeah, I second everything that's already been said. Contemporary racism is not a relic. It's like Alexis Jamal, who's a critical social worker. She likens oppression to a virus. It mutates over time to evade detection, adapting to new social norms and legal protections while continuing to infect our systems, our policies, and our institutions. So as was mentioned, where, historical racism was blunt, Jim Crow laws, redlining, overt exclusion, today it's refined. So we've moved from signs that say whites only to standardized testing policies, insurance denials, merit-based hiring practices that yield the same exclusionary outcomes. We still see school districts segregated by race and income. As Mary Joy mentioned, Black and Brown patients remain untreated and undertreated for countless conditions. The ranks of academic and clinical leadership remain overwhelmingly white. And now DEI efforts that were meant to address inequity are now being defunded, reframed, and dismissed as divisive. And so the shift in racism's form, it mirrors the shift in its defenses. So it's no longer protected by those white hoods and lynch mobs that Kelly just mentioned, but by spreadsheets, bureaucratic language, and so-called race-neutral policies. It hides in plain sight under the guise of objectivity, tradition, and efficiency. If historical racism was a sledgehammer, blunt and unmistakable, contemporary racism is a scalpel, precise, institutionalized, and hard to detect. It often goes unnoticed unless you're the one being cut. And like a virus, understanding contemporary racism requires more than just studying its history. We have to track its mutations. And addressing it, that's going to require a full body response, not just treating the symptoms, but building collective immunity through truth-telling, policy change, and structural healing, which is why
we
we're here
do
today.
need some truth telling up in here, but I love what you said about, and I wrote it down, it goes unnoticed unless you're the one who gets cut. So when we think about, next slide, please, what you all just said, how it mutates over time, but it's yielding the same outcomes. In what ways have current policies perpetuated or interrupted inequities? And let's start with you, Kelly.
Oh, this is a tough one. I have a hard time finding the ways it interrupted inequities. When you look at these past 73 days, there have been so many policy changes, executive orders, that it just makes your head spin and difficult to keep up with all these changes. But the current policies in the United States continue to play a pivotal role in shaping equity and access across all different sectors. We're talking about education to healthcare to even our criminal justice system. So, and these policies have attempted to disrupt long-standing disparities and perpetuate inequities. And some examples, the first one being dismantling the DEI programs. That is our biggest threat. The playing field was never been the same, and we had these policies in place so that we can remove some of these systemic barriers and historical disadvantages. So when you dismantle these DEI programs, it makes it even harder for underrepresented individuals to obtain jobs, to enter into college, career advancement. And then we don't think about the other effect. It increases discrimination, decline in reporting of these discrimination mechanisms disappear. Workplace inequity increases, and then it creates a negative workplace environment. And then you think about some of the other Global effects, withdrawing from the World Health Organization. Let's think about what the effects, the detrimental effects are going to be from that. The WHO is instrumental in monitoring emerging health threats such as COVID-19, setting the standards and developing guidelines for health threats, assisting with humanitarian responses. So there are going to be individuals, particularly in under-resourced countries, that are going to go without receiving food, water, healthcare, medicine, vaccines, and the essentials that are needed to survive. This is going to really lead to a strain on global community and impact indirectly health in the United States. And then one last thing I'm going to mention is the calling for the closure of the Department of Education is going to cause significant financial challenges for individuals, particularly among marginalized groups, since we have a disproportionate amount of the student loans. Having this now go to the business department, they're not going to be able to handle the amount of loans in this portfolio. And then it makes you think, how is this going to affect people that are going to college? People who are trying to pay off their loans. Oh, sorry, somebody's microphone is on. And then we think about too, educational funding. We mentioned that before. This policy where schools get funding based on property taxes in itself is already setting up for a disproportionate amount of money going into Black and Latino communities. These policies perpetuate inequities, such as educational funding. Affluent neighborhoods obviously are going to get better technologies. They're going to get more teachers. They're going to get more resources, guidance counselors, which can affect students' ability to go to college. So these are just a few of the examples of how that these policies continue to perpetuate inequities. And there's a few that have helped interrupt inequities. And with the budget cuts, I hope that they still exist. One of them being the Affordable Care Act, which expanded health coverage and introduced protections that have some reduced some gaps when it comes to access and reducing the uninsured and historically marginalized populations. But again, this is still on the line and they're trying to make it even harder with more paperwork. So we have to try our hardest to protect that. And then the last is the student loan forgiveness efforts that really have been aimed to reduce financial barriers to higher education, particularly for borrowers from historically marginalized backgrounds. And again, we got to make sure that we maintain these few policies that are helping marginalized communities.
Kelly, thank you for emphasizing the Affordable Care Act and how it has helped to interrupt inequities and how you really can't tease apart access from quality. And the access is there, but there's some room for improvement, definitely, with quality. Danica, you want to add anything?
Sure. When I think about, just to Kelly's point, it's easy to come up with these policies that continue to perpetuate racism. One that I think about is policies that disincentivize the inclusion of those closest to the problems that we say we're trying to solve. And so that could include students, faculty, staff, patients, families, and the communities that we serve. When we end up excluding the people with lived experience, we stay stuck, replicating the status quo, refining outdated systems rather than reimagining new ones. So part of the problem lies in the questions that we ask, questions shaped by faulty theories. So instead of asking, why do racial disparities exist? Instead, we should ask, how have policies, laws, structures, etc., created and maintained the racial inequities that we see? The first question assumes that racial groups are biologically distinct, that there's something inherently wrong with certain groups. But that second question recognizes that race is a social construct, that it was created to justify and to sustain unequal systems of power. And as Mary Joy alluded to earlier, involving people with the lived experience is essential to making this shift. They help us reframe the questions, challenge dominant assumptions, and design solutions that are actually grounded in the realities of those most affected. So their insight is not supplemental, it's foundational to creating just systems. We also have to shift from measuring race to measuring racism. Race is not the risk factor, racism is. So again, there are bright spots. One example I have is the Justice Squared initiative that's developed by the Robert Wood Johnson Foundation in partnership with We in the World. And so this effort is funding teams, but these teams have to include leaders from both the healthcare system as well as leaders from the communities that they serve. And they're assessed not just on the strategy in terms of their application, the proposal application, but on their commitment to collective leadership and power sharing. And so each team is going to focus on one of two transformative shifts, either measuring racism instead of race, or removing racism from clinical algorithms. So these are more than just projects. These are beacons of hope. They show us what's possible when we commit to both equity and imagination.
Definitely. Mary Joy, anything to add to that?
Yeah, I think my colleagues here have really articulated where the lack of policy in terms of promoting diversity, equity, and inclusion will need to be continually addressed and assessed, especially that we are looking in different directions on how to support funding for this type of initiatives. I know that organizations have created chief diversity officers and other initiatives to promote cultural competency training within the interaction with our patients. I know that we have included social determinants of health. So this way we can really assess what are the continuity of care that these patients will be needing when they go back to the community. Are we able to help them along as they continue to cope with their disease conditions? So I think embedding this information within the electronic medical record have helped us and put us to that direction. But at the same time, how do we continue to sustain this type of improvements, especially as we incorporate other technology in reducing discrimination, as it is already been diluted within our databases, right? So it goes back to how well are we going to support policy that will really help us address racism, not just from a policy perspective, but in the structures and processes that we have.
Yes, thank you, Mary Joy, for emphasizing the importance of addressing the structure. We can't emphasize that enough. Danica, you had shared a great example of targeted universalism when you said no one should die during childbirth. Can you talk a little bit about how we foster targeted universalism to advance as a society?
Yeah. So this idea of targeted universalism has been put forth by John A. Powell and others from the Othering and Belonging Institute out of Berkeley, and they call it Equity 2.0. If you'll advance the slide, Sarah. And how he classifies equity 1.0 is where you have a disparity. So normally we have a reference group, generally that ends up being whites, and then we have the group that's having the disparate outcome. So in the case of maternal mortality, Black, birthing people 3 to 4 times more likely to have bad outcomes in and around childbirth. So equity 1.0 would say, let's just close the gap and then we're done. But what he asked is, what if those white birthing persons, what if they don't have what they need? So the fact that you've closed the gap, you haven't really done anything in terms of the greater population. And so what he suggests is equity 2.0, where you have a universal goal. So what if the universal goal is that nobody dies in and around childbirth? So again, they say that most policies either treat everyone the same, we're just going to give everybody the same thing, or they target one group without connecting to a shared goal. And we see these programs under attack now. Those programs are vulnerable to political, changes in climate, et cetera. But they offer targeted universalism as this third way, a smarter, more effective path to equity. So again, you start with a universal goal. It's a goal that everyone should be able to achieve. So does everyone, no one dies, in and around childbirth. And the key is that the goal is shared by all, but we don't assume that everyone starts from the same place. So we have to recognize that different groups have different needs. And so then you assess, so how is everyone doing in terms of meeting this universal goal? And so the core insight is, while the goal is the same, different groups face different barriers to reaching that goal because of history, policy, current conditions, all the things that we've enumerated, in this series. And so some people might need a ramp, others might need language access, some might need structural change. And so then you design strategies that are targeted to each group. And so targeted universalism means we don't erase difference, we recognize it, we study it, and we design strategies that meet people where they are so they can get to that universal goal. And so again, most universal policies fail because they assume a level playing field. And most targeted policies can be politically divisive. So targeted universalism is powerful because it starts with what we all want, and then it gets specific about what different groups need to get there. And so if we think about that equity, equality analogy, the visualization with the people on the boxes that we're likely familiar with, targeted universalism is not just about redistributing boxes so everyone can see over the fence. It's about asking, why is there a fence at all? Who built it? And how can we make sure everyone can see the game, no matter where they're standing? And so targeted universalism gives us permission to dream big about the future that we want and the practical tools to help get everyone there, not by pretending we're all the same, but by recognizing our differences and designing equity from the start.
I love it. And I love, why is there a fence? Forget about reassembling the boxes. That's awesome. Mary Joy, what are your comments about targeted universalism?
I really love how Danica had expanded our imagination and challenged us. How do we achieve targeted universalism? And you mentioned about equity, right? And this is where I saw this quote, which is very appropriate. Equality gives everyone the same shoes. Equity gives everyone shoes that fit. Targeted universalism gives everyone the shoes that fit and gets them to the finish line together. And I think that's what our goal is, right? In terms of like addressing access to care, barriers to our patient. How do we assure that we're providing the best care possible for our patients, especially underrepresented community? Do we give them equal access the way that we're giving other populations? So I think this will be a very great discussion in terms of just brainstorming. How do we do this together?
Yeah. All right. Awesome. Kelly, anything to add?
I just wanted to add some key strategies because I love this principle of universalism. A couple of things that sometimes we don't do a great job at doing. Number one, that I think is important is getting the data, because in order to identify the needs, you have to get the data. And I think a lot of times we don't collect it, number one. And sometimes we don't want to collect it because we don't want to uncover some of those truths. And the other piece that I think is important too is making sure that we engage communities, the affected communities, in co-creating those solutions. I think is so important. So many times, we have people come in and like, we have the solution for you. We're going to come in and we develop these solutions, and we realize we haven't included the stakeholders, which are the people that live in that community. So that's another thing I just want to pinpoint. And then to follow up after this wonderful plan is put together, to make sure that we have laws and policies that align to make sure that these goals will be successful, and to make sure that we monitor the plans and revise as needed. So it's not just a one and done. This is a continuous cycle.
Definitely. And just to go back to what Mary Joy shared, don't just give people shoes that fit. Really make sure that we get them to the finish line. And Kelly, that's what you're saying. The policies have to align with the laws. And we haven't seen that consistently. And therein lies part of the problem. And we have to realize that we're communicating sometimes with individuals who are at different levels. If we think about Piaget's cognitive development theory, we assume that because we're adults, that everyone has progressed through the different stages, and some have not, right? Some are not able to think concretely. Some are not able to think abstractly. They're thinking in ways that are self-serving, that's demonstrous, that is just creating such incredible hazards, not just in healthcare, but to your point, Kelly, on a global level, that I'm trying to think, how are we going to resolve what we're going through today 4 or 5 years from now? What would that look like? So I want everybody to have an opportunity to go into the breakout sessions. We have 3 really strong questions for everybody. Danica, do you have any instructions for the facilitators regarding Padlet? Because we've never done this before.
Yes. Do you want me to go over the elephant rider path?
Yes, please.
Okay. Before we go to our breakthrough rooms, as Bart would say, I want to give us a quick mental model that can help guide us about how we think about change, individually and systemically. So it's the elephant, the rider, and the path. It's a metaphor developed by psychologist Jonathan Haidt and then popularized by Chip and Dan Heath in their book Switch. So the elephant in this metaphor represents our emotions and motivation. So the elephant, this is our emotional side, the part of us that's driven by hope, by fear, compassion, resistance, or energy. It's powerful, but without direction, it can get stuck or it can run wild. So in our breakthrough rooms, this is your motivation for the universal goal. Think this is your why. Why does it matter to you or your community? So we want you all to come up with universal goals. So an example might be no one dies in and around childbirth. That stirs something in all of us. And so in addition to the elephant has a rider. And so the rider is our rational side. It analyzes data, it makes plans, it weighs pros and cons. The rider is great at thinking, but without the elephant's energy, it can overthink it or it can stall out. So again, in our breakthrough rooms, this is where you'll explore what's worked before or what might work to reach the goal. So the rider helps us name systems, policies, and structures that need to shift. And so the third part of this metaphor is the path. So the path is the environment and the structures. This is the context that we operate in. Even a motivated elephant and a smart rider will struggle if the path is full of barriers or leads in the wrong direction. So this is where, again, targeted universalism comes in. The path isn't neutral. Some groups face more obstacles than others. So we need clear direction. We need to clear the path, reshape the path for different groups so we can all reach this same destination. So in your breakthrough rooms, keep this in mind. Your universal goal is your destination. The elephant is your why. Why do we care? The rider is how we think it through. And the path is what we must reshape in order to make that goal achievable for everyone. And lastly, reflect on what you personally are willing to do. So this is a personal commitment you'll make to guide the elephant, to steady the rider, or to reshape the path. And we want to give you all permission to dream. How many times do we have the opportunity in our spaces to dream and imagine? So you get to shape the future that you want to see. And so we have a Padlet. Your room facilitators will either appoint a scribe, but we have a Padlet where you all will jot down your universal goals, just toss out ideas. You'll jot down, what you've seen work or maybe what might work. And then there's a space for that personal commitment to just chime in. What are the things you're willing to do? And then there's some space for resources that maybe you need and resources that you already have. And so you'll have access to that Padlet even after our time is through here today.
Thank you. All right, so we have 28 minutes to get this done. I'm looking forward to hearing all your thoughts when we come back. So let's go out into the breakout rooms. Thank you.